we look at lymphoma, let's take the example of a 55-year-old male with night sweats, palpable adenopathy, both in the abdomen and the supraclavicular region. Why might we consider PET imaging? Well, one is if we want to know the distribution of disease, that's a great way to see the distribution of disease. In some lymphomas, we may consider radiation to treat a limited focus of disease. Also, we may want to use it for directing biopsies, so to make sure that we're biopsying an FDG-avid component of the lymphadenopathy. We may be dealing with a CLL patient who has a blastic transformation, and we want to identify where the transformation is so that we make sure and biopsy that. So this is a patient with lymphoma, and you can see that there are intensely FDG-avid nodes in the supraclavicular region, in the lower mediastinum, and in the retroperitoneum. Notice this patient also has polycystic disease, and in some of these areas you would not be able to distinguish tumor if it was mixed in with these cysts, but the PET is extremely helpful in ruling out tumor amongst the cystic lesions. If we look at pancreatic cancer after treatment, after chemoradiation and after a Whipple procedure, we're presented with some other problems, and that is that those treatments affect our imaging. And so we want to consider an imaging test that won't be degraded by the post-radiation inflammatory changes or the post-surgical scar tissue. So for example, in this patient, there's a focus of recurrent tumor in the right upper quadrant, and the CT finding is very ill-defined. You really wouldn't know whether or not this was just post-radiation inflammation or scar tissue. And then after treatment, the FDG uptake resolves, but the CT finding looks almost identical, so you really benefit from PET in a case like this. If we look at liver mass evaluations, whether it's a single mass or multiple masses, we often want to characterize the mass and determine what is that mass, and also determine the precise anatomy of where is the mass, how close is it to blood vessels, what segments are involved, how many lesions are there. And CT is pretty good at this, but MR is even better. And if, for example, we have many sequences that we use with MR, each of which gives us slightly different information. We can look at T2 signal, which here the mass is almost iso-intense to normal liver. We can look at pre-contrast T1 signal, where again the mass is almost iso-intense. And then we can look at the contrast enhancement pattern and conclude that this is almost certainly a focal nodular hyperplasia, a benign tumor. We also have different contrast options with MRI. We can use the standard intravascular contrast agents or the newer hepatobiliary contrast agents. And so in this patient with a liver mass, we can see that the tumor enhances, and on the late 20-minute scan, it retains the hepatobiliary contrast, which is essentially diagnostic of focal nodular hyperplasia. In this patient, we can see a very bright T2 mass that is sharply marginated but lobular, classic for hemangioma. And we can also look at the dynamic contrast enhancement pattern and see the discontinuous enhancement. And notice that with MR, we don't have that radiation penalty that we do with CT scanning. So we don't mind doing multiple phases of contrast enhanced scanning to confirm a benign hemangioma.